Hey everybody, welcome back to my channel, and if you are new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, and give us a thumbs up. Today, our guest is Dr. Scott Holmes, and he's going to talk about GOATA, greatest of all time athletes, and how he combines the method with MDT. Dr. Scott is McKenzie certified and GOATA credentialed. I hope you enjoy the show. Hi Scott, welcome to PT Pro Talk. How are you today?
Good. How are you today?
I'm doing good. So thank you for accepting my invitation. I'm curious to talk about this new topic. So jump right in. Could you tell us a little bit about yourself, your career?
Okay. Well, hey, and thank you again for having me on here today. I just like this, this opportunity to share about GOATA and just be able to learn more myself and hopefully help some other people in the process. I'm Scott Holmes, physical therapist. I've been practicing since 2010, so about 11 years now. I'm in a rural town in West Tennessee. I'm in the middle of nowhere, so redneck West Tennessee. A small town called Milan, but basically it's a city of about 7,500, 8,000 people, but I pull from larger areas around it. Grew up playing sports, college, went here locally, then PT school here in Tennessee. But one thing that really kind of, as far as, this is more mechanical based MDT podcast, I got introduced to McKenzie approach MDT my last year PT school. I was actually having neck problems at the time. So imagine that. PT school couldn't fix it. My professors actually made me worse. So I deranged bad. They moved me the wrong way and they couldn't fix it. So within my first week there in my internship, my third year, I was seeing people, they could not abduct their arm at all. I'm like, oh, and then my clinical instructor, 𝗂𝘁, he, was doing tons of retraction. And I'm like, what is this guy doing? And they retest the baseline. I'm like, oh, got more motion, keep going more. And, the 50 reps first session, and she had full abduction. I'm like, okay, I need to learn this. And sure enough, learning those principles right off the bat, this is my story, but this is how I got into it, was within a week after progressing from retraction to retraction extension, I'd abolished all my neck pain. And so that's kind of my intro to MDT. And I was a student, so I didn't have as much stuff in my head. It was great. So then from there, practiced, kind of bounced around, moved back home for a little while, and had to do some home health stuff to make ends meet. But I knew that I was getting good outcomes with it, but I needed more mentoring. So I had two options. I had to go diploma route or go work under diplomats at IMC. And I chose that route because I had a connection there. And that really changed and my efficiency. And so I had so many areas that people like Mark Miller, Paul Swart, Alan Sawyer, Mancor, all those people down there, they helped me a ton. So I'm still trying to learn. But yeah, that's how I got, more advanced in MDT. I still got a lot to learn. And then from there, came back, tried to implement some of it in the hospital system, beat my head against the wall for a year or two, or 2.5 years. And I said, okay, I'm just going to start my own. And I started all cash in rural West Tennessee. It didn't work. So I'm in just a handful of networks. And so a little hybrid clinic, just me. You can see nobody else, just me. It's kind of nice. But yeah, that's my history. And then from there, I get introduced. Lynn Graham's a friend of mine, and she told me, we were in a cash mastermind group at one point, and she just said, you've got to check out GOATA. This is really changing things. It helped her get rid of some knee pain she'd had. And I knew knee pain in MDT cases sometimes can be a little stubborn. And so, once you rule out the spine, that's great when it resolves there. Once you rule out knee derangement, that's great. But then you get something conclusives that are a little harder to treat with knee OA, things like that. And there were some things I knew I was probably missing. And so it's helped me a lot. That's how I got into it. I actually have a little knee pain myself and still do, but it's helped me a ton because it's more like a contractile issue. I got a leg length discrepancy and I'm a mess, but it's helped a ton. So
So let's talk about this GOATA movement. So what is it and how does the method work?
Okay. GOATA is greatest of all time actions or athletes. It is. So basically it's a method designed to help make you non-contact injury resistant. So like the ACL tears that happen, non-contact, they can prevent them. I don't think they've had a single case of one of their athletes who stuck with the method ever get a non-contact. So it's crazy because they've identified the pattern of movement that a lot of people get in and cause injuries with running, walking, things like that. So that's what it is. You look at the feet, you have to get the feet straight, the inside ankle bone high, the rear end's got to be back. It's called back chain dominant posture. There's about 6 pillars that they go off of, but it developed to know where this came from. It was developed off of slow motion study of babies as they start to crawl and walk, that pattern. And then looking at athletes who had long, healthy careers, Hall of Famers who had low injury rates, and also like the aging, they call them the aging GOATA, who are in their 80s to 100s who can run and jog and still move like that. And so they found a consistent pattern, and that's how it developed. And it was developed by a guy named, I'm going to butcher his name. So Coach Gill is what we call him, Jose Bosch, or Coach Jose Gilly Bosch. But he put together bits and pieces of different systems. He found the parts that worked, and he was just watching a ton of slow motion video and had noticed a few unique things in the pattern and put it together. And he is not a medical professional. He got sick of the medical profession, and he found some answers himself because he had some, disc issues and all that, back pain, and it helped him a ton. So yeah, that's what GOATA is. Slow motion assessment, using lines to point it out. It helps, us see it better, helps the patient see it better. So buy-in's easier. And it cleans up on loose ends for MDT.
Okay. So just a question. Do you use slow motion on your practice, or it was just used to develop the technique and then you just identify the postures and go from there?
Great question. Yes, I do. I use it in my practice. So it depends on the patient. Usually within the first or second session, I'm doing it because I want to catch it early on so that you can track the progress, the before and after. So yes, I do. If they're real complex and lots going on there, I at least try to show them some things, because some of them, if they're like, let's say they're a lumbar derangement, you get their footwork cleaned up even on that first session. It's like, get your feet straight, put the weight on the outside edges of the feet. They're like, oh, my pain's less. And their derangement reduces faster. So it's like, because you're decreasing the load, putting the body in the positions it's supposed to be in. Because, they may not talk about this as much, but knowing the anatomy, which we know a lot about, if you put the pelvis forward, let the feet pronate, the hips internally rotate and the glutes just kind of shut off. You get the feet straight, put the weight on the outside edges of your feet, and put your bottom back. The backside starts to fire again. It's like, okay, there's something to this. These guys, it's like, man, I'm missing some things. And the biggie is that inside ankle bone low posture, the pronation. You see that ankle drop, all your shock absorption gone, there goes your ACL tear. So one of the things they'll use is the inside ankle bone drops, the Achilles pops, or that's where your ACL shred is. And so that's the biggie. They're preventing a lot of those things. So yes, I use it in practice. I use it every day.
Very interesting. So how do you apply GOATA in your practice?
Okay. Well, you look for the low hanging fruit, just like with the MDT assessment, you're trying to look for that, get a concordance sign and try to find the biggest problem they have. Because the thing about GOATA that's a little bit more, MDT is very complex. I mean, we know it sounds so simple, but it's really not. It's complex in a way that you're looking at a bunch of joints at once. So I'm trying to pick the one or two areas that movement issues that are the biggest problem. So if you see their feet are really tired out, I would first work a lot on just get their feet straight, inside ankle bone high walking. And so that's how I implement it. I'll do that. I'll do groundwork. So groundwork is the basis of how we develop. Like right now, I'm sitting in the floor. I'm sitting crisscross, but that in COATA, where you sit on your feet, your toes turned under, not W sitting, but basically it's COATA. It's I can show you, but you can watch little kids. Do you have kids?
Not yet.
Well, but basically, you sit on your feet, your toes are tucked under, so that restores that ankle plantar flexion inversion, your knee range of motion, the torsion there at the knee, and also the hip interrotation. So many people lack that. You get them in the floor, they're screaming, and they cannot. A lot of them cannot extend their hip very well, and so that affects how well they walk if they're an athlete and they run. So this method, I use it every day in practice, and that's I'll target a joint or two, especially like the feet. I'll get on the ground, have them crawl. Once they learn how to crawl, they stop, how most people's thoracic spine gets so stiff and doesn't move well. That starts loosening up. They'll start moving side to side, and they got a little swag in their walker. They call it the GOATA wiggle. So yeah, that wiggle is huge. That wiggle's huge. I've still been doing it more than a year now, but I got home the other day. I was like, why is my left knee hurting? And I'd been riding and leaning more, and my right side was forward more. I'm like, I'm not getting my head over my right foot. I'm not pulling my right shoulder back. And sure enough, I started walking around the house. I'm like, oh, it's going away. So it's neat, and it's hard to treat yourself sometimes, but that's what the slow motion video helps you look at yourself too. So,
Nice. I read something about pressure wave on the patterns. I was looking at the website. So what is that?
Yeah, really, because I know this podcast, it'd be easier to see it. But so pressure wave, I'll show you. I'll speak and I'll show you a picture while I'm speaking.
People can watch on the YouTube later.
Yeah, they can watch there.
To the podcast. I'll put on the YouTube so you can watch it.
But simply put, if you see pressure wave here, that you'll see when you load and you land on one side, that the foot will be straight, the inside ankle bone will be high. You'll see the knee go out 22.5 degrees in the sternum. So you can see that right there, like on Barry Sanders. Mm-hmm. So that knee is out, the chest is out. So that's that energy wave that you load on one side, and you load it and then you explode it to the other side. And so that's that energy wave, because energy doesn't typically move in a straight line. It's usually in waves. And so that's a lot of the theory behind it, is that our body may move in a straight line, but we are loading, and we're basically, you watch a baby crawl, they wiggle. And the good crawlers are the good runners and sprinters. You watch most of your running backs or sprint athletes, those guys, they've got some swag to them, and there's a reason why, because they're loading efficiently. I don't know if you've ever seen the video of Michael Johnson critiquing Usain Bolt. Guess what? Usain Bolt beat your record, dude. So you see him, you can see him load that. You can get on there, watch Usain Bolt slow motion. You can see him load that side, knee out, chest out, boom. And, he's got even has a significant leg length discrepancy. He's still, set records. So that's what it's based off. People like that who moved well and did really well. So you are basically trying to identify like the wrong patterns that people have and try to correct them and make it more efficient. So exactly. And so I deal with athletes and everything, but most of my patient population has been everyday Joe. So this has actually helped me start pulling in athletes and start doing more training. High school athletes and all that. I'm not working with pros yet or anything. That's Coach Gill, Coach Gary. I'll refer them to them if you're like real high level there. But so if you move more efficient, you're probably going to hurt less. So
and like these super athletes, like did someone teach them how to do this, or do you think that's something natural, or like what you just identified that on them?
So all those ones, at least the examples I said, that was just. They were that way from birth. They'll say that's your birthright. That's your innate movement pattern. We get out of those patterns from sitting in chairs and shoe wear and slumping, those basic things. Jobs sometimes, like even simple as like hairdressers, they'll throw their pelvis forward. You'll see that thoracic spine flex. That is a backwards movement. Chair is a backwards movement. It's reverse. It's our reverse gear. You sit in a chair and you see the lumbar spine, pelvis flex, tuck under like if you were to get out of that chair, you're going backwards. Your forward gear, your rear end's behind you, and you see the lumbar spine go extension, the greater trochanter sitting back a few degrees behind the lateral malleoli, and you're primed to go forward. And so that's that's what they're teaching. That's the theory, but really it does. I mean, I've seen inconclusive low back pain. You just like, get your rear end back more, and like, oh, it's gone. So, but
so that's the indigenous tribe pattern that I don't know how to say it, but
that's our innate movement pattern. And we just, unless you've probably got some developmental disorder, neurological type problem, that's how you come out moving. Like I've got 8-month-old twins right now. They come out, you'll see those nice pretty bows in their legs. Their inside ankle bones will be high. And one of them starting to rock, getting ready to crawl. That's part of the groundwork you do. Like literally I have 80-year-olds in here rocking on the ground. And then I put down foam tiles now because the turf I had was too hard. The old knees didn't like it. So yeah, that's basically it in a nutshell there.
Yeah. And how do you use it in relation to MDT?
Okay. So classify, assess, was it the ADTO model, or that's Ron Donaldson's book, or I'm funneling every patient. You use the symptom location time frame as a constant intermittent. What makes it better, makes it worse. The things that, us MDT therapists know, like the funnel is where it's at. Like get my provisional classification, rule out the spine if it's an extremity problem, derangement, just go down the list. I'm doing that every time, but I'm taking into consideration also the slow motion with it of like, okay, what other repeated and sustained postures are they getting in? Am I missing anything? Is there something else that could be, it's like the better worse section. You watch that's kind of part of your better worse, and it's part of your objective testing too. So it's just basically like MDT on steroids. Like you're doing some of the IMC training I did along with that. So it's a lot of involvement, but that's how I implement it. I'm ruling out derangement like all other MDT therapists do, ruling out the spine if it's an extremity problem, and incorporating that into it to help fill in gaps. So yeah, it's not complicated. It's just a step at a time, learn it and do it. And the more you do it, you'll see where it fits in.
And do you think you use in most cases, or in few cases, and like how like do you see that in your practice?
I'd say most. So like, MDT started Mr. Smith, posterior lumbar derangement. Okay. Let's say they're responding to extension. And when I start doing, functional exercise, maintenance and recovery function, I'm looking at some other things like footwork and just throwing in functional exercise like squatting and things, and showing them how to move and squat more efficiently in the back chain. Just testing some other things that could be deficiencies that may lead to injury. It's part of their recovery function, basically. So if it's like a clear cut, I got this, boom, then I'm still same process, but that's part of add that in there, the functional exercise recovery function part. So
it's pretty much like, for example, if you see a derangement and centralizes, it gets better. And even though like you apply that, you try to have maybe like long lasting results, and making sure that, because even that they take care of the posture, they're sitting the whole day or like something like that. So do you think that helps you on the prevention of the recurrency of the derangement, for example, or?
Oh yeah. And I will say, like, for example, you'll get a little faster resolution. Like let's say somebody, I've got several golfers because I've been a golfer and don't play as much now because I'm busy, but you'll see on their hind leg, their right leg will be toed out more. And a lot of them will be posterior derangement. You've been backwards. Oh, I'm great. But I work in on that, and they'll reduce faster. You get that foot straight, you load it more efficiently, and they're like, it may be gone that session. So yeah, in some of that, as far as let's say extension, centralized, abolishes all symptoms. I'll still include a little bit of that. That's just a guess at that point if it helps with prevention at that point, but shouldn't hurt as long as they know how to test their motions and symptoms and how to, do their prophylactic care. It's kind of add on for them, But I do know that some, you see that cause and effect. You add it, and bam, it starts to reduce even better. So yeah,
it's interesting. So The next question is like, what are the results that you see in your practice? So you're saying that pretty much sometimes it's instantaneous, and sometimes it helps on the, the prevention.
It can be. And so like in your derangements, it's going to be a rapid change. In your inconclusives, as long as you've ruled things out right, but I have people who I'm like, this thing looks inconclusive. I don't understand it. And I get them on the ground, I start rocking, they crawl, and they get up. And they're like, I'm 50% better. I'm like, well, dadgummit, that was a derangement. I'm not sure which direction got it. But but that's the beauty of some of it. It's not as specific. Like in MDT is very great at classifying. And we all know that you can implement MOBs. It depends on if you manipulate. I don't. But you can use different procedures like Mulligan techniques or whatever, still, if you need to use those to reduce it. So that's where it fits in. Like it was a derangement. I've had derangements reduced with crawling on the ground because they were loaded too far on one side. And they just needed a ton of reps, get in the floor and crawl for 5 minutes. So, it's crazy. I tell patients, go tell them your therapist said to crawl on the floor and see if they look at you like you're nuts. Just don't tell your doctor that.
Oh, that's crazy.
Yeah.
Who would imagine?
Yeah, I didn't, but I got frustrated with a few patients. And I'll tell you real quick, because you said the results. The two that caught my eye, I was like, I have got to get certified. The very first one, he was a locomotive engineer. I'd treated him 3 times. One of them, I kept him out of back surgery. He would shift correction, progressing back to sagittal plane, all that stuff. He's like, I'm good, I can function. He had psoriatic arthritis on top of that. Little sleep, very inconsistent. So sciatic pain, came back another time, helped resolve a shoulder issue. Came back again, same shoulder issue, and had a cervical component. You could extension or side bending would go down the arm. And sure enough, we could get some partial resolution. But the more I started looking at slow motion video, and Lynn was helping coach me, he was side bent and rotated to the left. I'm like, I don't care how much I push you this way in the clinic, I can't get it to stay. And, it makes sense. He's an engineer. He's looking out the window all day. He's like, yeah, I'm in there beating and banging on. I don't have a good seat, and I'm looking to the left. I'm like, well, dadgummit, you're looking at a shoulder surgery or neck. They may go in and operate on the wrong joint. Go walk. Because when he was walking, his head and shoulder, he wasn't getting that 22.5. He wasn't loading that pressure wave on the right side. So I said, go get your head over your right foot, turn that right shoulder back, I showed him the math, and he got it. He's really, really aware of his body. And so I said, walk 45 minutes a day. Because at the time he couldn't walk maybe a mile and a half, and he was done because of pain and everything. Within 2 weeks, he was up to 4 miles a day. And he said, you're not going to believe this. It's been 10 years. I have very little to no pain when I first get up. And most of my day I'm pain free. I'm like, and he came in, he was straight. He was not this way. He was back straight. He's like, this is a miracle. And he kept doing it. And he checked in with me just to say hi about, 4 or 5 months later. Dude had lost 50 pounds. Like, he's like, I can move and walk again. I'm like, I need to learn more of this. So
that's awesome.
He was one. Another guy, patient I treated before, he came to me, had a mild entrapment because he'd been to see somebody else for a year and just was lazy, and it got stuck. And adding the crawl and the other stuff, and I had to do the whole remodeling process with him for like an entrapment, but I also had to incorporate moving more efficiently. He'd been on pain meds for 20 years and got off of them. And he said, you're not going to believe this. Like, what? He's, doing GOATA, crawling, learning to move more efficiently. I can get off the medicine. Like, oh, wow. So those 2 cases were just like, I'm sold. I know, it's going to help, a lot of people. So, I think if, one of the questions you put on here was like clinicians starting their career, get MDT certified or more and learn GOATA. So, I know there's other methods, but just my thoughts.
Yeah, I never heard about it before. It's so when did this method start? When it was created? Do you know?
I may have Coach Gill, and I may have Coach Gill, and then fill it in more. I think it was 8 years ago or more, 9, or like whenever he kind of putting everything together. And formally, I don't know, the last several years I've really been teaching courses. So And it's the neat thing about it for me has been, it's not just PTs, because the PTs are actually fewer. It's mainly just trainers. So I had to apply to get it approved in the state of Tennessee. So if you're in the state of Tennessee and you want to get credentialed, you can. If you have questions, I had to submit it and I got it approved for, oh gosh, it was almost 30 hours. But it was really, I put in a lot more time than that, but it was worth it. So, but it's been neat because you get to talk to PTs, chiros, whatever. Don't shoot me, but it's good because, I think we're all out there trying to help people, and you see things from different perspective. And GOATA has the same mindset as MDT of helping make people be independent. They'll say the goal of the recode, which recode is recoding the way you move. The goal of the recode is to not recode. It's like the goal of MDT is for us to get to the prevention prophylactic stage where they can self-treat. It's the same thing with them. So that's why they mesh so well, because the mindset's the same.
Okay. My mind is just going here. So for the ones that do telehealth, like me, I do a lot of telehealth. Do you think that can work through telehealth? Like, how do you would analyze in slow motion, or like you don't have to, or how do you see that?
Oh yeah, I've got telehealth cases I use with it solely. I've got one in Florida right now, one in Chattanooga. So, hey, here's another side note. Because if it's coaching and you do it as a wellness package, you're technically practicing as a coach at that point. So that's if you're doing just strictly recode, not PT services. So yes, it can. And there are plenty of GOATA coaches who have way more experience than me who do just solely, they mainly do it remotely like you do, like telehealth. So it meshes well. Because you're looking at slow motion video and you say, hey, you can do a screenshot and show it to them and say, this is the posture you're in. We got to get over here. Let's work through some drills, do one thing at a time and see what helps you get more to that position. So the slow motion would be more to help the therapist to analyze it, or to show the client to make them understand, or both? Both and.
Both. Okay.
Yeah. It helps us both. It's just like, the repeated movement assessment. It helps me understand you understand what's going on with them, and also the patient can get that buy-in. They're like, oh yeah, they see that cause and effect. So it's kind of both and. Yeah. It's really helpful to like getting people in the door, even if they are simple posterior derangement needs to bend backwards, but you get a video like, hey, dude, your walking's jacked up. We might need to look at your feet, but it does help them in the prevention prophylaxis reducing. So it helps with getting people in the door too. It's a little easier sell than sometimes explaining MDT can be abstract. We know it works. We know all the data and the research is there, but this is a little easier to say, hey, yeah, look at this. And I send them a few screenshots and a little video assessment. Yeah. And they're like, oh yeah. So yeah.
Cool. So I'm just curious now to ask you about the contractile dysfunction. So that's probably I know it's probably all related, but I imagine like that, especially these type of dysfunctions, I imagine that would really help to let them not compensate and use the muscles more efficient too, right?
Yes. Like in my experience, because I've got one leg longer than the other, I had a hip surgery when I was 26, but on the hip that I have, my problem is contractile dysfunction, the right knee, patella tendon, but my right hip doesn't move well. And that actually happened because my left foot, I had a bad ankle injury and I wasn't pushing off efficiently off that side. And so that right hip the heel was jamming the ground. I didn't even know it. And so, yes, you get the footwork cleaned up, take some load off of it. You start putting more load. Like for me, I was putting all the load through the quad in the front. And if you look at studies looking at elite runners, I'm not a big runner, but they have more of a balance. They use more of the backside of their body. And so I had to get more. Yes, it can take load off the contractile dysfunction and also even assess motions of other joints that could be contributing to it. So contractiles can be easy if you just have that simple, I've ruled out the spine, I've ruled out derangement, I just need to load it slowly and progress it. But then you run into the ones you're like, dadgummit, it's not getting better. What am I missing? And that was me. I'm like, I've done all the slant boards, I've done eccentric, I've done backward walking, I've done ISOs, and I wasn't seeing why.
They go back to the same pattern, and then the dysfunction is there, right?
Yep.
Yeah, that's interesting.
Yeah. So I know they can be complicated too, but GOATA really kind of sheds some light on that too. So this is where I'm saying like the two systems mesh so together, and they're really not against each other if you really use them the way they're supposed to be used,
Yeah, absolutely. So let's transition to our final question. So what is your favorite resource of information? Anything that you like in particular that you want to share with us?
One, I know I start people out with who I had an intern recently. It was just Ron Donaldson's Rapidly Reversible Low Back Pain. I know that's what got me kind of like, I'm more left brain, like facts, data, whatever. But that's what my instructor did with me. He said, okay, read this. And it made me start thinking, everything's low back pain's a black box diagnosis. It's generic. So it got me to thinking about assessing, diagnosing, basically using the funnel and the problem we have in America. So that's a big one. Other resources like for just ongoing learning, JMMT. I use Google Scholar some and other search engines for that. But like, I know Google Scholar, you got to filter through what's good and bad, but that's basically where I'll go. So anything the McKinsey Institute puts out too. So
the same book that Yav recommended. You just did that.
Is that who he recommended? Yeah, he's a great guy. A lot smarter than I am.
And do you have any other advice to the clinicions? Because you already said the MDT and the GOATA, sorry.
Yeah, everybody gets it wrong. It's all good.
I knew it was going to happen at some point.
Advice, I would say, so this goes back to my wife and I have been involved in ministry too, that there's characteristics for people you look who can really grow and flourish. Of course, this is ministry, but it really applies to everything, that they're faithful, meaning that they're responsible. They can be consistent. Just be consistent when you're learning, whatever method you learned, especially MDT. Be available. You've got to have some time set aside to be able to learn it. Like, if I see so many clinicians who they're just patient, go home, I got all these things planned, and they don't take any, Paul Swart gave me really good advice when I was in Tallahassee. He just said, when you got the manual here, read through it, just spend 15 minutes a day. That's it. And just be consistent. And so you got to have some availability to learn. That's why I like my hybrid, a little small PT practice here, because I can do that. I love that stuff. And just be teachable. Like, be willing to eat some crow at times, because you're going to be wrong. That's what Lynn told me about some cases. She's like, you ready to eat some crow? I'm like, sure, just tell me. But faithful, available, teachable. Those are the acronym that we use, so. Yeah. But I think that's good for any part of life, really.
Yeah. Absolutely. And what personal qualities or abilities that you think are important to become a successful PT?
Oh, I guess I got those backwards when I answered. Those were
were.
Yeah, that and I guess going back on what I said about MDT, like find a reliable assessment treatment method, which I'm biased. It's MDT, and then get GOATA credentialed as well. But I know there's other stuff like out there, that things that I want to learn too. I'm 35 and got 4-year-old and twin 8-month-olds. So I'm a little busy right now, but I'll keep learning.
We want to do everything. We just don't have time to do it all.
Yeah. Us being humans, a limiting factor for sure. But yeah. But awesome. That's my advice, is just get a good, reliable. That's why I so recommend Ron Donaldson's book, because it's like, why do we learn all this other stuff if the assessment method is not reliable in the first place? Like, your outcome's going to be off. So, so that was just my thought.
Yeah. Awesome. So Scott, if people want to learn more about your work or contact you, how they can find you?
They can find me Facebook, Scott Holmes PT, or Holmes Physical Therapy. There's one in Massachusetts. I'm in Tennessee. So Holmes Physical Therapy. They can find me on Instagram, Scott Holmes PT. I'm not super active there. more on Facebook. And then I've got a website. It's scottholmespt.com. Everything's pretty basic because it's a one-man show and I'm not that great at marketing.
Yeah. I think we all have the same problem, PTs.
Yeah.
That's awesome. So thank you so much, Scott, for taking the time and sharing this. That's very interesting, the topic, the GOATA. So as I haven't never learned or listened to it, I know a lot of other PTs haven't too. So I think it's great just to start talking about it and letting people know that there is a great option there.
And I think a neat thing that I want to throw this out there too is that if you want to get credentialed, let me know. I can answer some questions. You can contact me there. Also, if you don't want to go through all that, I do some consultations for people. Like I can see them for a few sessions and get them back to you. So that's an option too.
Nice. Okay, good. So thank you so much, Scott. I really appreciate your time.
Hey, thank you. It's great being on here.